a very warm welcome to everyone listening in, and welcome to this Global Healthy Living Foundation and Arthritis Power hosted webinar titled More Than Just a Headache, Understanding Migraine. So for everyone listening in, Global Healthy Living Foundation, or GHLF, has been conducting these educational webinars for over a year now. My name is Shilpa Venkatachalam, and I am the Associate Director of Patient-Centered Research at the Global Healthy Living Foundation, and I'll be facilitating tonight's webinar. So one of the goals of these webinars that we've been conducting is to share cutting-edge research and information on a range of different chronic disease topics with patients, caregivers, and other stakeholders in line with patient-centered research. Before I can hand over to our very esteemed speakers for tonight, we just have a few quick housekeeping rules to go through, and I'll go through this quite quickly. So this webinar is being recorded for those who are unable to listen in live today, or for those of you who would like to perhaps even go back and review the information and listen again to the webinar. A recorded version of this webinar will be posted on the Creaky Joints website. To ensure good quality audio recording, all audience members have been placed on mute. This will help us avoid any kind of background noise and to ensure we have good quality for recording for today's webinar. However, we do encourage questions, so feel free, please, to use the chat box that you'll see on your screen on the extreme right hand for most people. And you're welcome, and we encourage you to send questions throughout the webinar. Our speakers today will speak for about 30-35 minutes on the topic of migraine, after which we will have a question and answer session. We'll try our best to answer as many questions as possible, but please do keep in mind we have 1 hour for this webinar. So if your question remains unanswered, we'll find a way to get your questions across to our speakers after the webinar. Now for the good part. I'd like to introduce our very accomplished speakers for tonight, Dr. Dawn Buse and Dr. Yelena Pavlovic. Dr. Buse is a member of the Board of Directors of the American Headache Society, a clinical professor of neurology at Albert Einstein College of Medicine, and a licensed psychologist with 20 years of experience working with people living with migraines and chronic pain. She has to her name more than 100 scientific manuscripts published on migraine, pain, and the effect of this disease on important aspects of life. So welcome, Dr. Buse. Dr. Pavlovic is a neurologist and headache specialist at the Montefiore Health Center and assistant professor of the Albert Einstein College of Medicine. She is board certified by the American Board of Psychiatry and Neurology and is a member of the American Academy of Neurology, the American Headache Society, and the International Headache Society. She too has published extensively on migraines in women and is funded by the NIH and the NIA, the National Institutes of Health and National Institute of Aging, to conduct research on this topic. Dr. Buse and Dr. Pavlovic are both members of the Society for Women's Health Researchers Interdisciplinary Network on Migraine, with whom we've worked very closely on bringing this webinar to you, so a special thank you to them. So today's topic is migraine. Migraine is a common disabling neurological disease that affects 14% of the global population. A migraine attack is not just a headache. It's a set of complex systems, including pain, nausea, and sensitivity to light and sound. It can last for days and often interferes with aspects of life for the person experiencing it, and so has very disabling impacts on the person's life. So in today's webinar, both our speakers will discuss what migraine is, how it is diagnosed, and whom it affects. We'll also talk a little bit and review current treatment options and highlight new areas of research in migraine. So with that and without more delay, I'd like to thank both our speakers, extend a very warm welcome to our audience joining us today. And at this point, I'll hand over to Dr. Pavlovic.
Well, thank you so much, Dr. Venkatachalam, for this wonderful introduction. And thank you for this initiative to you and the Global Healthy Living Foundation. And also thanks to the Society for Women's Health Research, which, as you mentioned, Dr. Buse and I have been extensively involved with. And we appreciate this effort to focus. I'm just trying to figure out how to share my screen. I'm showing my screen, but this is a manuscript I'm working on that says migraine during menopausal transition. So I need to figure out how to share the actual presentation.
Dr. Pavlovic, on the very bottom in the middle, the little last icon that looks like a snowflake. Go to that little icon in the bottom middle that looks like a snowflake. There you go, that one. And I think that one. Yeah, go to that one.
Yeah, I'm doing that. It's not.
I'm happy to show the slides, and I can.
I had it open, but it somehow disappeared.
Okay,
Could you
no
please?
problem. Yes.
Okay.
There we go.
Okay, great.
Okay, thank you.
Thank you for that. Sorry about it. These are our photos.
Well, we can see that you're really doing the research there, Dr. Pavlovic.
Exactly. Thankfully.
Yes.
It's a good thing.
That's right. Yes. It didn't open to online shopping or anything. We can see that you're working hard for people with migraine, advancing the research.
So it was already mentioned, what is migraine? So migraine is, rather than what commonly is considered in lay terminology migraine, as I have a migraine, it's just another headache, and hasn't everyone experienced a bad headache? Well, no, migraine is actually a disease. And increasingly, we, those of us who live in this world of migraine by practicing and providing help for migraine, prefer the use of word migraine rather than having migraines, saying which really implies kind of just another headache, using the word having migraine as a disease which has its manifestation primarily as a headache, but in reality is this common disabling neurological disorder. And it is primarily characterized by debilitating migraine attacks, which are really severe headaches, but also by other symptoms. So in order to distinguish a migraine attack from some other headaches, we classify migraine and specifically define it as moderate to severe head pain that, if untreated, can last between 4 and 72 hours. Migraine can last longer than 72 hours, but when it's longer than 72 hours, we refer to it as status migrainosus. And that with itself carries a secondary level of treatment, a more intense treatment need. And this pain is often accompanied by nausea, by sensitivity to light, sound, and other symptoms, often vertigo, just feelings of unsettling, and many others that we can go through if we have time. Next slide, please. So I said moderate to severe head pain. I mentioned the sensitivity to light. Important to mention is migraine, an accompaniment of migraine, which is aura, which is really sensory disturbances. And most of you have probably heard of visual auras, which is the most common type of aura. Aura is present of all people who have migraine, only about 15% have migraine with aura. And that carries with itself certain consequence, but it's important to recognize that aura can not only be visual, so the kind of flickering light spots or lines, blind spots, loss of vision, that's a typical visual aura, but aura can also have other manifestations such as numbness or muscle weakness, often language difficulty. There was a well-known broadcaster that years ago during the Grammys had a language aura, a young woman who started sort of stuttering and muttering while being on camera at the Grammys, and it attracted a lot of attention and turned out that she had migraine, and this is how migraine ended up in the news. But the point being that it can have different manifestations. Next slide, please. Types of migraine. Migraine can also be divided based on its frequency. That is, how many times a month does one experience migraine or headache, divided into chronic and episodic. Chronic, similar to other chronic pain disorders, is the condition when headache occurs on 15 or more days per month for 3 or more months. And episodic is anything less than that, so less than 15. So somebody who has only 14, quote unquote only, gets diagnosed with high frequency episodic migraine, but not quite chronic migraine. And the distinction is important because chronic migraine has specific indications for treatment, and therefore patients might be eligible for treatment such as Botox. In addition to this distinction, we also recognize menstrual migraine, which are particular attacks that occur around the menstruation, generally 2 days prior to the onset of menses and about the first 3 days of bleeding. And we can talk about that more. And then the aura, which are the sensory disturbances. Next slide, please. In addition to having migraine, and migraine being an disorder of the central nervous system, it also travels with some, I'm sorry, I have to transfer this. Can you hear me? Hello? Okay.
Yeah,
there's rain outside. There's rain outside, and it's a very, very noisy rain, a downpour. So apologies for that. The comorbid conditions are many. So it has been recognized that people with migraine, particularly women with migraine, have a lot of comorbid conditions. And especially in women, this is much more significant than in men. As you can see in the bold, that about 11 comorbid conditions on average are found in women with migraine versus 5 in men with migraine. So pain conditions such as arthritis, fibromyalgia, musculoskeletal disorders commonly travel with migraine. This sort of conditions, umbrella of chronic pain conditions. Respiratory conditions such as allergies and asthma travel with migraine and can tremendously exacerbate migraine episodes. So depression, anxiety as well. Migraine is considered, migraine with DORA in particular, a risk factor for stroke, and frequently seen increased hypertension. And there are some proposals that migraine should be considered a cardiovascular disease risk in women with migraine. This is only in proposal forms. This is not an accepted guideline, but there is evidence to suggest at least such discussion in the scientific world. Furthermore, epilepsy is comorbid and some other neurologic disorders like multiple sclerosis. Sleep disorders also have higher comorbidity with migraine, irritable bowel syndrome, and many more, as the slide indicates. Next slide, please. And Dr. Buse will take it from here.
Thank you, Dr. Pavlovic. So I've been really lucky, along with Dr. Pavlovic and our colleague, Dr. Richard Lipton, to conduct very large studies of who has migraine around the world. And very recently, the World Health Organization partnered on a large-scale study of who has migraine around the world. And their final number was over 1 billion, with a B, 1 billion people have migraine. And who that breaks down to is about 18% of adult women, so about 1 in 5, and probably many, many people who are listening or either have migraine or live with or love someone who does have migraine. About 6% of adult men. And then migraine can start in childhood. And so about 10% of school-age children also meet criteria for migraine. And we certainly see that it becomes more prevalent for girls, at least, as they go through puberty and start having menstrual cycles, that really starts to jump up pretty quickly during those teenage years for girls. So we don't want to forget that children can have migraine. We also don't want to forget that men have migraine too. And 6% of the American population of men, if we have 40 million Americans with migraine, that means about 30 million are women and about 10 million are men. So this is still a very big impact for everyone. But it really does have a very strong female preponderance. So women are really affected by migraine, especially in some of the busiest years of our lives when we are having careers and also have children, and also may have aging parents that we're caring for. So multiple responsibilities in midlife, and it's most commonly seen in the decades of the 20s, the 30s, and the 40s. And then if you want to move forward to the next slide, research that I've done with Dr. Pavlovic, we find that it gets better Can we move forward a slide? Gets better for most people, most women, after menopause is really completed. And if perimenopause starts around the mid-40s on average, and menopause on average in the U.S. is around 51, but it's around the mid-50s, really, when the hormones are really kind of calm and stable, that's when we might see improvements for a lot of women. So as I mentioned, all these stats here, about 14% of the population around the earth actually have migraine, and it's 2 or 3 times more common in women versus men, and it's most common in those midlife, very busy years. Of everyone with migraine, about 20% to a third will have 4 or more migraine days per month. So if you think about that, that's living with migraine on average 1 day a week or more. And for any of us, losing a whole day of our lives every week is a really big loss. Next slide, please. Of course, I'm sure if you're listening to this webinar, I don't have to tell you that. So that recent big study that the World Health Organization sponsored found out that migraine is actually the second most disabling condition on the planet, second only to low back pain. It's expensive. It costs our health insurance. It costs our medical systems. It costs employers, and it costs individuals. Not only does it cost the person with migraine, but we found out in some of our research that their spouses or partners are also financially affected, both by costs and also lost time from work. In addition to about 14% of the people on the planet meeting criteria for migraine, about 1 or 2% have chronic migraine. This Dr. Pavlovic reviewed. That is migraine criteria with headache on average 15 or more days per month. So that may be every other day, or it may be as much as every day of the month. If we can go on to the next slide. Again, there is a very high preponderance of migraine among women. And additionally, it may play out a little bit differently in women. Women may have longer migraine attacks, and a migraine attack can actually last for days when you consider the prodromal period, the aura that some may have, the headache period, and the postdrome. And Dr. Pavlovic and I are going to explain those 4 phases. It can be a day-long extravaganza of awfulness, multiple day long. Women may also have migraine attacks that are more difficult to treat. They may have more migraine-related symptoms. So like in addition to the pain, the nausea, the extreme sensitivity to light, sound, odors. I wish I could see all your faces of everyone who's listening. I'm guessing some of you are nodding your heads right now. I'm just going to guess that because I'm pretty confident people are probably saying, oh, that's me. And it may have higher levels of disability among women, so causing more missed work, missed school, missed social, personal, family time, vacations, holidays, caring for your children, doing household chores and responsibilities, needing extra help, picking up your kids from school, all those sorts of things is what we call disability. So all of those impacts on the important aspects of our daily lives. Next slide, please. So let's get into the meat now of what happens when you talk to your doctor and how can they help. So turning it back to Dr. Pavlovic, our headache expert neurologist doctor here. Dr. Pavlovic, how do you diagnose migraine?
Thank you, Dr. Buse. So one would go typically to a healthcare provider to have their migraine diagnosed. And this does not have to be a neurologist. Primary care providers should be able to diagnose migraine. It does help to keep, if one has a suspicion, experiencing a lot of headaches, recognizing maybe from the media that this sounds like migraine, but I'm not quite sure. Keeping a headache diary in preparation for their visit with a physician would very much help in diagnosis of migraine. But sometimes it may require a little more teasing out to arrive to the diagnosis. The important thing to recognize is that there is no definitive test to show you you have migraine. So there's no blood test, there's no MRI. In fact, an MRI or any form of imaging is not indicated in the diagnosis of migraine. Migraine is what we call a clinical diagnosis, meaning that speaking with your physician and providing your history, that is your story of how you live your life and what symptoms you experience should be sufficient to diagnose migraine. However, there may be some blood work imaging. It may be ordered sometimes to exclude other causes of migraine potentially. Next slide. So we will review in the next set of slides the ways to prevent and treat migraine attacks. And these will include lifestyle interventions, medications, behavioral therapies that Dr. Buse is an expert in and will comment on, neurostimulators as a new modality in treating migraine, and nutraceuticals, vitamins and natural substances that have been shown to have benefit in migraine treatment. Next slide, please. So lifestyle intervention, we know that living well helps people who have migraine. Now, that's often much easier said than done. So exercising regularly is good. Staying hydrated is actually essential. Consistent quality sleep, of course, helps. Managing stress wouldn't be great if we could all just manage with stress. Before this webinar, I said to a colleague, I have to go and prep for a migraine webinar. She looked at me. She's not a migraine neurologist. And she said, you look like you have a migraine. Are you sure you can prep for that? So, stress is all around us. Figuring out how to manage it helps, but it may not be end-all, be-all, and it may not always be possible. Eating a healthy diet is helpful, yet there are there's a lot of reports on particular foods being migraine triggers, and we can talk about that later in the Q&A. And the data, the science on that is not definitive. But I believe that one kind of figures out what suits them. So if you notice that something doesn't sit with you, you don't need your doctor's confirmation to eat or not eat the food that you recognize doesn't sit with you. And all of these can help a great deal. However, it is often very hard to implement them all. And even if they're implemented, it is sometimes very challenging to consistently implement them. And therefore, we also often need medications. Can I have the next slide, please? And in terms of medication options, we typically divide migraine treatment into preventive and acute. So preventive medications are used on a regular basis every day, regardless of whether the attacks are happening or not. We typically recommend them to patients who have 4 or more attacks per month. So that is generally what's considered a cutoff for recommendation of migraine prevention. And there can be of all these different groups. And then on top of the preventive, and the goal of preventive medications, broadly speaking, is to reduce headache frequency by 50% or more a month. That's considered good achievement, which still leaves about 50% of attacks happening. So if one has gone, if a given person has 10 migraine attacks a month, using a preventive agent and decreasing to 5 is considered a very good response, which can also be those 5 attacks can be very debilitating to a lot of people still. And for those, acute treatment will be used. Focusing on preventive medications on this slide, I would like you to notice that the first 5 categories, ACE inhibitors, angiotensin receptor blockers, different types of antidepressants, especially tricyclic antiepileptic drugs and beta blockers, these were all preventives that were used until last June, so until a year ago, when the first anticalcitonin gene-related peptide monoclonal antibody, Erenumab, was FDA approved. Until then, we had never had a preventive migraine medication that was specifically developed for migraine. All of these drugs were developed, as you can see, either for depression or epilepsy or hypertension. And then as a sort of a byproduct, it was discovered that they also have preventive effects in migraine. So the anti-CGRP monoclonal antibodies were first approved by FDA last June, and since then we have had Epidemiology was first, and we've had two more drugs approved since then, and they are now available for both episodic and chronic migraine. And the last drug here on the list, on botulinum toxin A, marketed as Botox, is approved by FDA for chronic migraine only. That is, the individual has to have 15 or more days of headache for 3 or more months to qualify for it. Next slide, please. So a little more about the anti-CGRP monoclonal antibodies, the first FDA-approved class that is for migraine prevention. CGRP, which has this long name of calcitonin gene-related peptide, because it's not a cytokine, it's a smaller kind of set of amino acids, thus just a peptide. It is a protein which causes inflammation in the brain, so central nervous system inflammation, and tends to be elevated from general levels in people who have frequent migraine attacks, and then has a tremendous surge during an acute migraine attack. So a lot of it is released acutely in a migraine attack. And these antibodies are the new class of drugs that bind specifically either to the CGRP receptor, one of the drugs in Renuma binds to the receptor, and the other the other two drugs bind to the ligand itself, to CGRP molecule itself, and there's a fourth drug in development that will be an IV infusion that should be approved by the FDA hopefully in the next year, that will also bind to the ligand. So there's several options, and although they all bind to the same peptide, they bind to different areas of the peptide. And they have been shown on average, these are of course generalized descriptors here, but on average they have been shown in people with episodic migraine to decrease migraine days by about 2 to 4 days per month. So about 50% decrease in migraine frequency on average, and also similarly in chronic migraine by about 6 to 8 days per month, which is significant. But what in terms of just headache decrease, but what we're also finding, which is happening in patients clinically, is that not only are the headache days decreased, but that the days remaining are easier to treat with established acute treatments that they have. So the headaches that do occur don't tend to be as severe as prior to preventive treatment. Next slide, please. And then focusing on acute medication. So when these headaches do occur and one needs to treat a migraine attack, whether they are on preventive agent or not, there are several options, prescription options and over-the-counter options. Over-the-counter options like acetaminophen, simple Tylenol, commercial name, NSAIDs are non-steroidal anti-inflammatory drugs. So most common are aspirin, which is not prescribed as often in U.S. for treatment of headache, but ibuprofen or naproxen, which commercially are Aleve and Advil. I'm sure most of you are familiar with and have used. And then prescription strength NSAIDs, diclofenac, nabutolone. There's a number of other sort of cousins of ibuprofen. Triptans, which were the drug class specifically developed for migraine treatment, but for acute migraine treatment, and which are typically not advised to be taken more than 2 or 3 times per week. There are also triptan and NSAID combinations. Ergot alkaloids are older medications, particularly ergotamine, and dihydroergotamine is somewhat newer, but they can have complications, though in some patients work really well. Anti-nausea drugs like chlorpromazine, metoclopramide, chlorpromazine, used for not only nausea, but may have some anti-pain properties. And finally, different kind of prescription strength combination of analgesics and steroids, which we will often go to when everything else has been exhausted. And when I mentioned that headache that's more than 72 hours long to break status migrainosus, we will use it in a short period for about 3 to 5 days maximum to break the status migrainosus in patients. One noted absence from this slide is lack of opioids. So opioids, due to their cause of though they have use in some rare patients, in general, due to the cause of hyperalgesia, opioids and opioid-containing combinations are not prescribed or recommended for treatment of migraine. Next slide, please. And here I will hand it off to Dr. Buse and to let us know about behavioral therapies.
Thank you, Dr. Pavlovic. I love hearing your description of the new CGRP monoclonal antibodies. You make a pretty complex topic understandable. So that was great. For behavioral treatments, these are the left three: biofeedback, cognitive behavioral therapy, and relaxation training. Literally have decades of research and hundreds of studies proving their efficacy as migraine preventive treatments. The nice thing is they can stand alone, and sometimes they need to. For example, maybe someone is pregnant or wants to get pregnant, and they know that they're going to need to stop many of their current medications or breastfeeding, or perhaps it's someone who actually wants to try something that's non-medication. And when they are combined with medication treatments, the efficacy rates just soar higher than behavioral therapies alone or medication alone. So they're really a wonderful addition to treatments. Biofeedback is a really interesting experience where literally your biologic information is fed back to you. So you get hooked up to a bunch of different leads, like sensors for galvanic skin response, which is in essence goosebumps and sweaty palms, your heart rate, your respiratory rate, muscle tension, and finger temperature. All these things matter because they are markers of sympathetic activity. That's just a big word for the fight or flight response. And when you're in chronic pain, you actually have activated sympathetic activity because your body thinks you're under attack, unfortunately. And we want to move you to, one, noticing when you have that heightened activity, and two, teach you and help you move to a state of relaxation. We call that the rest and digest response, and that's the parasympathetic branch of the nervous system. Cognitive behavioral therapy teaches relaxation training as well, and also adds an element of looking at what your goals and values are, helping you better manage life's challenges, and tweaking the ways that we see things and talk about things for achieving better outcomes. And when I see someone for CBT, I usually see them for about 8 sessions. It's not a forever psychotherapy. It's got a start and an end, and it goes pretty fast, and it's a pretty interactive psychotherapy with homework and exercises and things you try and things you practice. And so even if you've done a different type of psychotherapy before, a CBT for migraine or pain management is going to have some interesting, unique features. And if you want to see any of these, certainly there's videos online, and sometimes it helps just to say, okay, what does biofeedback look like, and what am I getting into here, so that you can kind of demystify the process. All of these may be covered by insurance. You just have to have the right diagnosis code, and your doctor needs to use the right CPT code. That's an insurance number. But these are all evidence-based, and they're really, I think, interesting to do, and they tend to have good effects on all aspects of your life. They also help stress and depression and anxiety and weight management and sleep and all of those things that are hard for all of us. So those are very well endorsed and recommended by all medical agencies and scientific communities around the world for migraine. On the right, the furthermost box, we've been testing out lately some other therapies which have strong evidence in other disease states like chronic pain, depression, anxiety, substance use, and smoking cessation, but are newer in the migraine space. Those would be the mindfulness-based therapies, which are very interesting to try if you have an interest, and acceptance and commitment therapy. So we don't have the hundreds of studies behind them, but if they sound interesting to you, absolutely that's something worth checking out, and there would certainly be no harm in learning more of those skills. And I'm going to pass it back to Dr. Pavlovic to continue on to the next slide.
Thank you, Dr. Buse. I always love your description of behavioral therapies because the evidence shows how helpful they are and how effective they are, particularly when combined with other modalities and other interventions in migraine. And now off to non-invasive neurostimulation. This is a new frontier in migraine treatment. And for those of you, particularly in sort of musculoskeletal pain world and who understand that and might have used TENS units, it's extrapolating from that. So these are devices that use electrical stimulation to then alter nerve activity and in that way reduce neurological symptoms. So currently there are several FDA-approved devices for prevention and acute treatment of migraine. So one is a single pulse transcranial magnetic stimulation, and this used to be a very sort of a unit for which one had to go to a special center. Now there is a portable unit that can be rented from a company, and one places it in the back of their head and releases, just presses a button, and magnetic stimulation is emanated, it's received to the back of their cranium. It was originally approved for depression treatment first and then showed really good evidence for migraine treatment. I have used it. It's easy to use, it's pleasant, and it's I didn't use it in a consistent way, but at least as a promo, it found it effective in a short run. Transcutaneous supraorbital neurostimulation is more like the TENS unit, meaning that it's electrical stimulus delivered to supraorbital nerves, which is if you touch right above your eyebrow, that sort of sensitive spot on the first part, the part of the eyebrow closest to the nasal bridge. One has two little foramina there. Those are two little holes that come out of the bone and the nerves emerge, and those nerves are then stimulated. And that stimulation has shown to have good effects in preventive treatment of migraine, and the device is FDA approved for it. And then finally, the most recent approval comes to vagus nerve stimulation. Vagus nerve is the nerve that runs sort of on your neck. So the little device stimulates, it's placed on the neck and stimulates the vagus nerve there, and again can be used for acute or preventive treatment of migraine. Next slide, please. And these are very good in those who would like to avoid medication or for whom medication are not working effectively, or who are already on great polypharmacy, on a lot of medication, adding an option that is not pharmacologic provides a lot of freedom. Nutraceuticals, finally, nutritional supplements have been since old ages used in migraine. Before we had pharmaceuticals, we had nutraceuticals, and people recognized that they can use them for treatment of migraine. Butterbur, different ones have different level of evidence. The best evidence exists for butterbur, which is an extract of a plant, of a root plant, and it's an alkaloid plant. And the challenge there is that the extraction needs to be pure without alkaloids, which can potentially be liver toxic. So while evidence is actually very good, and it was in one point as prescribed as first-line preventive treatment for migraine, there has been some challenges in consistently finding alkaloid-free preparations from different manufacturers. So just bear in mind that is something to look out for with butterbur. While the extract itself is very beneficial. Coenzyme Q10 can be beneficial, but needs to be used in high doses, and the data is not as persuasive as that for butterbur. Similar is true for feverfew, magnesium, and vitamin B2, with the caveat that magnesium has some good evidence or decent evidence in treatment of menstrually related migraine. I often suggest to my patients when presenting evidence and saying, well, the evidence may not be very convincing, but these are things that are easy to try, that are generally considered benign, and if they work, great. So if one is skeptical or not yet sure if they would like to go on a long-term prevention, they can always try a nutraceutical option, and a lot of patients have obtained good headache control with these options. Next slide, please. So in terms of this, what's new, I think we've covered the monoclonal antibodies, that the CGRP monoclonal antibodies that are now FDA approved, with the fourth one still in the pipeline, that have really truly changed our field and brought new attention to it in the last year. Also in the pipeline are CGRP receptor antagonists. So these act on the same sort of a path, on the same road, same mechanism, but they are small molecules and they're different. They're not antibodies. And this group of drugs will be called gepants, and they potentially will be available for both acute and preventive treatment, while the monoclonal antibodies are available only for preventive treatment. These are under study and will hopefully be coming through the pipeline in the next year or two. Serotonin receptor agonists, this class of drugs is called D10s, and these are also coming through the pipeline, probably a few years away. Research these days, there is increased focus on migraine and increased funding in migraine research, but of course still not sufficient, but better than it was 5 or 10 years ago. And we are very grateful, as Dr. Buse and I, as researchers in the field, are very grateful for that, but are hopeful also that there will be even more attention and recognition of this generally under-recognized disease. So the research is focused on understanding the pathophysiology, how things come about, why and how and when. Role of hormones, because this being the disease of women, as Dr. Buse outlined earlier, clearly hormones have a very significant component in part to play in migraine, and my research specifically focuses on that, but so does research of others. Disease burden on individual and beyond on the society. Migraine is often seen as a silent disease, so though individuals continue to go on and even appear to thrive, they do so at a great cost for themselves and for the society at large. And we really need to understand this well and to be able to communicate this to powers to be, so that there will be research dollars behind it. Barriers to care are many, and we can talk about them in Q&A and much more else. Next slide, please. And so finally, I'll just say a word about the role of hormones. We know that sex hormones, and this has been recognized since the ancient times, that they contribute to migraine in women. And this is believed to be one of the reasons why migraine is so much more common in women than in men. We said 3 to 4 times more common in women than men. And migraine prevalence also changes across the woman's lifespan. So hormones affect migraine in women across the lifespan from puberty, because migraine typically emerges around the time of puberty with menarche and menses. In pregnancy, because the estrogen level is stable and hormones are very stable, it typically improves. So women with bad migraine will often say, oh, wow,
wow, pregnancy was my best time, at least a phase of pregnancy, which is not something one hears commonly from women who don't have migraine. Postpartum migraine will often worsen, and then during perimenopause, migraine can fluctuate a lot and have a real increase in frequency due to hormonal fluctuations. And finally, postmenopausal fluctuations, when all the hormones quiet out, migraine can often improve. And then we also know that migraine fluctuates across menstrual cycle in women. So this is where estrogen withdrawal and estrogen fluctuates across the menstrual cycle. So when estrogen drops, which we refer to as withdrawal, that seems to be a hormonal trigger for women with migraine, precipitating this menstrually related migraine around the period. And the important part to recognize that is that estrogen withdrawal happens few days before bleeding. So the menstrual migraine will typically start 2, sometimes even 3 or 5 days prior to the onset of bleeding, and not at the time of bleeding generally, though it may be at the time of bleeding. And we need more focus in this area to truly understand what are the mechanisms of this. Next slide, I believe Dr. Buse will tell us more about stigma and understanding why we need to work more to spread the gospel of migraine.
Absolutely. Thank you, Dr. Pavlovic. So I am guessing the people listening to this call, if you live with migraine, can tell me what stigma about migraine feels like. We know that there's both internalized stigma, so kind of self-embarrassment, guilt, and shame about maybe responsibilities that you miss or time away from work or family, and then external stigma, which is how other people view someone with migraine, so how coworkers and bosses and family members view someone with migraine. And we've been doing research in stigma and find that it's incredibly high, actually, and we think that this stigma towards people with migraine creates challenges for getting good care, for getting diagnosed, for getting research funding. And we think that it's possible that because migraine is so prevalent in women, it might be kind of feminized and a less legitimate disease. And this is certainly where migraine came from decades ago, as being a woman's headache, a sick headache, and more of a personality issue rather than now the disease that we know it to be. Next slide, please. But even though we have that science, we still have to sometimes fight against those old notions of migraine being something that's a personal weakness rather than a brain disease. Interestingly, in the U.S., we find that less than half people who meet criteria for migraine are actually seeking treatment from a healthcare professional. Maybe they don't know that they would be taken seriously. Maybe they don't think that there are treatments that can help them. Maybe they don't think it's something their healthcare professional wants to hear about. And so we find in our research that people delay treatment or they don't seek treatment. And so while we have all of these effective treatments that Dr. Pavlovic and I just reviewed, if people aren't getting to their doctor, they're not getting them. So we really, both Dr. Pavlovic and I, as well as the Society for Women's Health Research and the Global Healthy Living Foundation, Creaky Joints, want to really implore anyone living with migraine, or even if you don't know if it's migraine, if you have severe headache and you ever get nauseous with it or have sensitivity to light or sound, please do talk to a healthcare professional, because the treatments are there and we want you to get the treatment you deserve. Next slide, please. What else can you do? Well, I just said talk to your healthcare professional, get your diagnosis, get your treatment plan. It's out there and you deserve it. Next, remember those healthy lifestyle habits that Dr. Pavlovic went through. We know Dr. Pavlovic and I are human too, and we don't always exercise as much as we should, and we're both moms, working moms, so neither of us get as much sleep as we'd like to. And I don't know if we eat regularly, so we know it's not easy, but we do know with migraine, someone with migraine has a hypersensitive nervous system, and the hypersensitive nervous system likes consistency. As much as possible, go to bed at the same time every night, wake up at the same time every morning, eat your meals right on schedule. If you need help with any of this, for example, if you need to be able to take your breaks at work or keep a water bottle at your desk, ask your doctor. We love writing those notes, don't we, Dr. Pavlovic? we love telling someone's boss that they have to have their water bottle with them for a medical reason, or that they have to take their break for a medical reason. So don't be afraid of that. You deserve it. Learn more about migraine. There's some great resources we're going to go through at the end of this presentation. Next slide, please. And now I'm going to talk kind of fast for the next couple of slides so we get some Q&A. There are clinical trials available. You can find them on clinicaltrials.gov, clinicaltrials.gov. And you can actually try some of the medications that are being treated. Now, sometimes you might get the active medication, sometimes you might get placebo, but it might be interesting to try, and you help our cause because by bringing more people into research and bringing more women into research, that we learn more about how these new treatments affect women, and that's important. And also raise an awareness about migraine. You know, we tend to kind of keep it to ourselves and may feel shy about it, or may feel kind of embarrassed about it, but you know, we want to stand out proud and say migraine is a brain disease. It's the second most burdensome disease on the planet, and the people who live with migraine are warriors who still keep jobs and care for their children and care for their families and care for themselves and contribute to society and are awesome people. So we want you to hold up your head high and don't be shy about it, because we need the large masses of us to say that this is a real disease that deserves real funding and real good treatments. Next slide. So as I mentioned, clinicaltrials.gov is where you can see trials that are currently underway. We need diverse ages, races, ethnicities, and female participants so that we know how these new treatments really work with real people like all of us. Next slide, please. And I talked about raising awareness, helping to alleviate stigma, and really calling for increased research funding. And one way you can do that is talk to your representative. You can tweet or Instagram or Facebook or email to your congressman and say, I care about this funding. Please add NIH research funding for migraine. And they actually they do listen to constituents. They really do. That's something that Dr. Pavlik and I and hundreds of headache doctors across the country work on every year to try and get Congress to raise our NIH funding. And it's working. They're raising it. They're hearing us. And the louder we can get, the better. Next slide, please. Here are some great resources. And there's not enough time to leave them all up right now, but I want to leave it up for just a sec. If you have your phone, you want to take a screenshot of these, please do so. And also, this will be available for listening to again. As long as you had registered, you can listen to it again in the future, so you can come back to this. And on to our next slide, please. And here are our references. And again, you can come back to these. If you ever are curious to look at any of these original scientific references, they're all available online in a place called PubMed, P-U-B-M-E-D. And just put in PubMed, and you can actually read the abstracts for all of these and really find out what Dr. Pavlik and I and migraine researchers are really what's at the forefront, what are we testing, what are we learning on a monthly basis. Next slide, please. So we both, Dr. Pavlik and I, along with Society for Women's Health Research and the Global Healthy Living Foundations and Creaky Joints, want to really thank you all for giving us this opportunity to talk about this disease, which is so near and dear to our hearts. And we just have a couple minutes for questions, so we're going to jump right into those.
Great. Thank you so much, Dr. Buse and Dr. Pavlik. That was fantastic and a lot of great information packed in there. And just as a reminder to everyone, this information and the slide deck and the talk will be available on the Creaky Joints website. So you can very well go back and listen to anything that you might have missed or you want to review. So I know we're nearing the top of the hour, but I'm going to take a little bit of liberty today and add a few extra minutes so that we can ask at least 2 or 3 questions. because there was so much great information packed in here. I want to start off actually by talking about, you mentioned at the start the importance of the patient's story, and we hear this all the time in several of the chronic diseases that we deal with. So whether it's migraine or rheumatoid arthritis or psoriatic arthritis or ankylosing spondylitis, the role of the patient's story, the importance of the patient's story in that pathway to diagnosis, in the treatment of the disease and the management of the disease is of utmost importance, is what we hear over and over again from experts like you. And so thank you for reiterating that. And so I want to ask a question in the context of that remark, and these are actually a cluster of questions that I'm going to try and combine together. And the question has to do with a diagnosis. So someone in the audience asks whether a neurologist is the person to go to for a diagnosis as well as for treatment. But given that there might be, say, a significant shortage of specialists in a specific geographic area where the patient may be located, there might be certain challenges in getting diagnosed and treated. And again, this is an issue that we see in rheumatoid arthritis and ankylosing spondylitis as well. So can you talk a little bit about maybe what patients can do to encourage the specialty and how this is being addressed, this shortage of specialists, how it's being addressed currently?
So thank you for recognizing the importance of patient input, which, of course, you and your audience and the Creaky Joints is very aware of, because this is the priority kind of patient relating their stories and patients finding the physicians who will listen to their stories. I always say when we teach medical residents and medical students, I always say that it is not the patient's responsibility to present the information to us in a way we learned it in textbooks. It is our responsibility to help the patient tell us their story. So keep that in mind. If somebody is not able to hear your story, if somebody cannot put it together, maybe you need to go to somebody else. That said, majority of primary care physicians are equipped well enough to diagnose migraine. And what will help them is if you bring them a headache diary, if you tell them about your associated symptoms, if you tell them how much it interferes with your functioning and what it does for you. What I often find is that patients, because there is such a stigma of migraine, so frequently patients will be telling me the story of migraine, and it sounds like migraine, and then before they finish, before I've even said it's migraine, they say, but I know this is not migraine because that would be really bad. And the point is that, the more, though it may be, even the self-stigma that Dr. Buse mentioned about in migraine that exists, and that we all sort of, not all, but the majority of people can carry in the way that we were brought up. I certainly can relate to that as a person with migraine and my own stigma of migraine, in my own migraine. One should realize that we really gain as patients and people when we recognize this, because the suffering will exist whether we give it a name of, as long as even if we don't give it the main name of migraine, the suffering will be present and will exist. So naming it, and therefore getting the treatment that name kind of carries with it, can be very empowering. So that is the first thing that I explain to patients who are reluctant to kind of get the name migraine attached to them. And the other part in terms of how to, so a primary care physician should be able to. A lot of gynecologists serve as primary care physicians for young women, and they are often quite familiar with migraine, particularly these menstrually related migraine symptoms. Getting to a neurologist can be helpful, particularly if there are other somewhat complicating features, and such as aura or other things where a neurologist can kind of dissect better and maybe rule out some secondary causes. And of course, if this is a complex case of migraine that hasn't responded to sort of first-line treatment that primary care physician would generally prescribe, and maybe then secondary that a neurologist would prescribe, going to a specialized headache center, to someone like myself, or Dr. Buse, that actually specializes in headache medicine, it would be recommended. However, there is only several hundred of us in the country. Dr. Buse, correct me if I'm wrong. I believe that there's about 700 of us currently in the country, and most are situated in large urban areas, which leaves a lot of country without specialized headache specialists. There is an increase in fellowships, and an active recruitment into this area of neurology. But given the high prevalence of migraine, it will take a long time until, an active recruitment for there to be sufficient number of headache specialists for everyone who has migraine. And therefore, we have to partner with our primary care colleagues who can make a great difference in life of patients with migraine.
Great. Thank you, Dr. Pavlovic. That was very practical, useful information. I'm sorry, I know I'm keeping everyone a little bit longer, but just a couple more minutes so we can squeeze in maybe just one or two more questions. This is such great information here. So you mentioned comorbid conditions that may present for patients with migraine. Could you talk about if or not you see a higher prevalence of specific comorbid conditions by gender?
So yes, especially other comorbid pain conditions are more specifically found by gender. Fibromyalgia, the conditions that otherwise are conditions of women. So fibromyalgia is highly more prevalent among women, and we see highly more comorbidity associated with women rather than men. Anxiety and depression are also more commonly comorbid in women rather than men. IBS is a commonly found in women. Disorders like allergic rhinitis, for example, which exacerbates migraine frequency, tends to do so equally in men and women. So we see this preponderance, right, towards other comorbid pain conditions and things like autoimmune disorders like multiple sclerosis and so on. These tend to be more common in women. Migraine tends to be more common in women, so therefore the comorbidity and the overlap tends to be more common.
Great. Another question, and I think this is a question we hear very often, not just in migraine, but in many of the other chronic diseases that we work in. Patients always want to understand efficacy in terms of treatment and medications, and it's a struggle for patients because many times I think this is an unfortunately all too familiar experience that patients have, is that they might not respond to certain medications. So in the case of migraines, are there any indications to perhaps suggest that if a particular patient does not respond to an older migraine medication? You mentioned something about CGRP antibodies. Are there indications to suggest that patient might then respond to newer lines of therapy?
So if I understand correctly, if they haven't responded to other medications, can we infer whether they will respond to newer therapies from that?
Exactly.
Is that correct? So we do not have markers of response to treatment. So in other words, there is no blood test that we can run and say, at this point at least, currently in 2019, we do not have a blood test that's available to us that we can run and say, oh, this would be the best medication for you. And we also do not have really good, other than our clinical sort of intuition regarding patients. Sometimes help from family. I will often have a mom and then her sister and then two other daughters come over the years. So knowing what the family kind of tends to respond to, which gets at pharmacogenomics, can be helpful. But if a patient fails one preventive agent, there is no reason to think that they will fail the next, or to have that they will preferentially respond to one versus the other. We do not have that data. We do know, though, that patients who generally don't respond to preventive agents, if they haven't responded to 3 preventive agents, it is less likely that they will respond to preventive agent number 4. But we do not have data on predicting response to another preventive agent based on lack of response to a prior agent.
Okay, great.
Seeing something very exciting with new research that's all being published this year at the American Academy of Neurology and the American Headache Society scientific meetings. A lot of research was done specifically on people who other preventive agents did not help them, either for efficacy, how well it worked, or tolerability, side effects. And they looked at a lot of people who either 2 or even 3 didn't help them. And the new CGRP monoclonal antibodies are still helpful in a large percentage of those people. And so that's research which you're going to be seeing in the headlines a lot next month when we have our scientific meeting, and from a couple months ago at our American Academy of Neurology meeting. So there's definitely every reason to be optimistic and to try different classes of medication, different types of preventive medication.
Absolutely true, and thank you, Dr. Buse, for adding that. And the other point of that being the really good tolerance of the new drug class, the monoclonal antibodies. While a lot of other patients can fail a lot of preventive drug classes, not because they're not effective for them, but because they can't tolerate side effects, as I'm sure a lot of this audience is familiar with. And new drug classes are much better tolerated. And also the adherence with a once-monthly injector helps a great deal.
Great, and that's a really optimistic note to wrap up today's fantastic presentation. It's always encouraging, I think, for patients to know that there's options. There's research being done so that different therapies can be brought to patients who are dealing with these chronic diseases. So thank you for that information. We have a few questions in the chat box, just very quickly, that I'd like to respond to. So yes, this webinar will be posted. We've recorded the webinar and it will be posted on the Creaky Joints website. You will be sent information once it is up and live. We do have a list of other webinars that we've conducted on various other topics that you can access on the Creaky Joints website as well. If you go to the Creaky Joints website webinar page, so you might want to check that page as well. And then finally, to wrap up today's discussion, we have a number of questions that remain unanswered, unfortunately, given the constraints of time. So what we can do, given the interest in the topic and the request for information, is perhaps take these questions back to Dr. Buse and Dr. Pavlovic, get them answered, and post them up on the webpage along with the recording and the webinar. So if you have any additional questions, feel free to send them to us and also to the email that you see on your screen right now. With that, thank you so much, Dr. Buse and Dr. Pavlovic, for a really, really fantastic presentation today. I almost wish we had 2 hours for this webinar for all the fantastic information that you've provided us with. And thank you to our attendees for listening in, for asking all your questions, for staying a few minutes later than usual. Stay tuned for our upcoming webinars. We host webinars every month on various different topics, so stay tuned for that. And also special thank you to the Society for Women's Health Research, who have helped us bring this presentation to you today. So with that, thank you and have a good rest of your day.
Thank you so much. It's such a pleasure. Thank you.
Today's webinar was brought to you by the support of Amgen. Our sincere thanks to them for their generosity in supporting this webinar.